From the Library of Congress in Washington, D.C.
Welcome, everyone. Today's lecture was organized by the Science, Technology, and Business Division. I'm Tomoko Steen. I'm a research specialist here at the Library of Congress at the Division of Science, Technology, and Business. Today's lecture is on cancer nanotechnology, and nanotechnology is a frontier now, and House is also working on the new bill on the nanotechnology, and those who are working on it send me a apology not being able to join today. But today's speaker is one of the pioneers on the field, and he has been actually working very actively at the Johns Hopkins University. Professor Robert Ivkoff, he actually based at Department of Radiation Oncology and Molecular Radiation Science at the Johns Hopkins University's School of Medicine. And also he has joint appointment at Engineering Department of Johns Hopkins as well. And he is visiting researcher at NIST, and this crowd, NIST, is familiar for everyone, I hope. And he has been doing a lot of research collaboration at NIST as well. And his PhD is from University of Maryland, College Park. His master's from the University of Toronto. And his most recent project started from 2000. And he is not only researcher, inventor on this special technology. So before further ado, please join me to welcome Professor Ivkoff.
So this can serve as a sound check. Thank you very much, Tomoko, for the invitation. And it's a real pleasure and an honor for me to present to you today. I think I accidentally... Okay. It's just a little slow, like some of us early in the morning. To begin with, I think I'd like to just lay the groundwork to sort of prepare you for some of the themes that I'd like to try to bring across to you. And when Tomoko was communicating with me about this topic and to give a presentation, initially I thought, oh, well, I'll just talk about cancer, magnets, and nanotechnology and all this stuff. And then when I started working on it, I realized it's going to be a little bit more challenging to bring this across to a broad audience. So some of the themes that I'd like to bring across to you are that real innovation, real technology development, real advances, particularly in challenging problems, take a long time. They also require multidisciplinary approaches, and not just saying the words of multidisciplinary, but truly cooperation and having experts who really are not just expert in one particular area, but who have some expertise in a number of areas. And there's another one that actually comes to mind as well, and that is there's really nothing new under the sun. Many of these ideas are not new to us. They're old. We've been practicing as humans. We've been practicing nanotechnology for over 1,000 years. But what we do as humans is we tend to reinvent, we tend to not necessarily trace a circle in innovation, but a spiral. Every time we come back around to the same topic, we've got new information, we've got new technologies, new methods, and this brings about advancement. And so with that, as the prelude, and forgive some of the quality of these slides because I'm actually pulling these these graphical images from documents and information, because I wanted to really just display the information in the sources. So these are age-adjusted overall cancer death rate, overall death rate from a number of different diseases. And what one can see is that compared to other diseases, the overall age-adjusted death rate from cancer for the years 1958 to 2010 has changed very little. A note here is that this is on a logarithmic scale, so even a twofold change will just appear as a little slight dip. But having said that, one should be impressed, I think, by the fact that many other diseases have had marked decreases in the overall death rate. And that's an interesting fact. Notice particularly cardiovascular disease. We're approaching essentially a declining cardiovascular death rate and a flat cancer-related mortality rate, so that now we're probably, if these trends continue, we might start to see that cardiovascular death may not be the #1 cause of death. Interestingly, one can also dig into this and look to see Alzheimer's is really, Alzheimer-related death is increasing dramatically. So is this really a dismal figure? Well, actually, if one takes a closer look, a closer examination of cancer death by organ or by particular anatomical site, and on the top we have for men, and on the bottom graph is for women, you do see that there are actually significant decreases. Note, this is not a log scale, this is a linear scale, so any change is going to be magnified. But there is actually some change in the direction that we would like to see, where the death rate is declining. Lung cancer for both men and women is, for men it's a dramatic decline, but the reason is men were smoking earlier than women were, and cessation of smoking has caught hold in the male population more so than it has in the female, and so that's contributing to the decline. But notice prostate cancer. What I'd also like to highlight, I put the bar up here, this is roughly around 1971. 1971 was a watershed year where President Nixon signed into law major reform and funding for cancer-related research, driven primarily by patient advocacy. And I think this is an important point. And whenever I talked with people, or even friends, family members, and so on, it's like, why aren't you doing more about cancer? Well, actually, as it turns out, the war on cancer, I would argue, is having its effect. But notice, it's 10 to 20 years out from the time that it was begun. So to really have a meaningful impact on this disease, it does require sustained commitment. It's not a simple disease. So why do we have such a difficulty with cancer? Well, one way of looking at it is cancer is not a single disease. It's roughly 300 diseases. But more to the point, from my point of view, again, remember, I'm a physical chemist. I'm not a biologist. I'm not an epidemiologist, so I'm always a little bit nervous when I'm putting graphs like this up on the board. Cancer is a genetic disease. It's an autoimmune disease. It's a epigenetic disease. If one thinks about it, breast cancer, prostate cancer, death does not come from the local disease. So men do not die from locally advanced prostate cancer, typically not. Women do not generally die from locally advanced breast cancer. These people tend to die from the metastatic disease. And think about this for a moment. What does it take for a prostate or a cancer or a breast cell to migrate from its environment, take up residence in the liver, brain, or bone, and actually restructure its environment and take over? This is not something that is a simple, quick fix, little turn on a switch or turn off a switch kind of a problem. So it does require sustained commitment and a multidisciplinary approach from all fields of science. So now switching to nanotechnology. The concept of nanotechnology, and more specifically the National Nanotechnology Initiative, which began in 2000 when it was signed into I guess a law, if you will, by President Clinton, really, if one starts to dig around for the history of this, many times you often end up here. Richard Feynman gave a relatively famous lecture in the American Physical Society meeting in 1959, and it was titled "There's Plenty of Room at the Bottom," meaning there is a great deal of opportunity in science on the low length scale. So nanotechnology, as it is currently defined by the National Nanotechnology Initiative, is that it is the science and engineering and technology or practice of controlling matter, using matter on length scales of 1 to 100 nanometers. We have been doing nanotechnology for over 1,000 years. Stained glass windows in the cathedrals in Europe are essentially that way because of nanotechnology. So, when I was preparing for this talk, I asked colleagues at Johns Hopkins, who are part of the Cancer Center Nanotechnology Center for Cancer Center Nanotechnology Excellence. One of these is a radiology professor, Martin Pomper, who is also a collaborator on several projects. One example of nanotechnology-enabled cancer diagnostic imaging is through the use of this, and I won't go into the name of it and so on, but it essentially is a nanoparticle that has been labeled with a very specific molecule that binds to a particular receptor on prostate cancer cells. It's a prostate-specific membrane antigen. I'll show you some other slides and some work that I'm doing with other collaborators on this a little bit later in the presentation. But prostate-specific membrane antigen is one of those markers, or it's a protein that tends to be upregulated or expressed in great quantity when prostate cancer metastasizes. Not very often found in high levels necessarily. I mean, sometimes it is, but it's not always consistently found at really high levels in the primary disease. But when prostate cancer metastasizes, it tends to be overexpressed in abundance. So what they did was they attached a nanoparticle, and then they used this particular isotope of fluorine and this PSMA molecule to initiate a study in imaging a patient who has prostate cancer. And what one sees is that with a regular CT bone scan, one doesn't see the cancer, but hopefully the lighting is sufficient that you can actually see that they were able to find tiny lesions in the bone that were not apparent by traditional scans. So one example of nanotechnology-enabled imaging for diagnosis of cancer. One reason why one might say that the breast cancer rate and prostate cancer rate might be declining is better screening methods, earlier detection. So I like hunting around for pictures on the web when I'm starting to prepare talks. And this one caught my eye. Initially, I chuckled, and I was going to discard it. But then I thought, no, wait, there's something interesting here. First, I would like you to look down here. This red bar is representative, for example, to scale, width of a human hair. What we are talking about is manipulating matter and making machines that are on the same sort of a scale, like relative to the human hair, like that. So when I looked at this, I thought, oh yeah, that's something from Star Trek. I just started laughing, was going to throw it out. But then I sat back and I thought, wait a minute. It's an interesting thing about the length scale here. Because if you think this is far-fetched, look at this. The size scale that we are talking about here is the size scale of a virus. And viruses are actually extremely sophisticated machines that do exactly this. They respond to their environment. They know exactly when to release their genetic material. They have all this complex signaling that goes on to do what they're going to do. Otherwise, they wouldn't have survived. So anybody who works in this field knows that the size scale that we're talking about, we might even say it glibly, the size scale that we're talking about of nanoparticles is really on the order of the size scale of a virus. But I don't think we have spent enough time thinking about the full implications or the logical conclusions of this. So one of the themes that I'd like to bring out here is to say that many of this might actually be possible if we begin to think about nanotechnology in the right context. And I think that's actually something that we haven't, in the nanotechnology community, haven't really begun to do yet. So the virus does a lot of things that we think is science fiction if we think about engineering materials. But by studying the virus, I think we can begin to accomplish some of the goals that we set out to accomplish in healthcare. So why is this so important? Why is the size so important? So nanomaterials, I think, are very unique or very special, in part because of their size. And this is a general statement. This is not necessarily only applicable to biology or medicine, but when materials are taken down to a very small size scale, then the surface area becomes a much greater proportion of the total amount of material one is dealing with, and now the surface properties become significantly enhanced compared to the other bulk properties of the material. So electronic properties, magnetic properties, even quantum effects can become significant and play a role. So we can use this to our advantage. Anisotropy, in other words, something that is not equal. Okay, so we've got anisotropies in shape. We can have elongated particles, we can have various types of square or rectangular particles. The shape of the particle actually has a significant effect in medical applications. And if you doubt that, look at the virus. So we have other anisotropies that become important in surface chemistry. This, I think, is, in one sense, one of the reasons why nanotechnology-enabled products are facing some technological hurdles. It's because we have not yet figured out exactly how to control that chemistry or what we need to do, because viruses have already figured that out. And that's one of the themes that I want to bring out in this talk, and I'll use examples from research to emphasize that. So it turns out that the chemistry, the chemistry of the surface, the physicochemical properties, actually determine how this material is going to interact with your body. Because if your body thinks it's seeing a virus, it is going to treat it like a virus. And so here is just a cartoon, but this, I think, makes the point very nicely. These are particles that I've developed and worked on several years ago, and these were antibody-targeted anti-cancer particles that have magnetic iron oxide crystals that we could actually initiate heating with an external magnetic field to do therapy. So I'm giving you a little bit of a foreshadowing of the topic. These particles are about 40 nanometers in diameter. And there is a discussion, there has been an ongoing discussion in the nanotechnology and cancer, and that is targeting doesn't work. And then there's some sides who say targeting does work, and then targeting doesn't work, and so on, back and forth. So the only thing I would have to say to that is, if targeting does not work, then why would natural selection have given viruses their ligands that are very specific to certain receptors on the cell? So the viruses are very much targeted, so it must work. We just simply haven't figured out how to do it. That's my hypothesis. Another interesting thing that I believe has real medical implications is that when we bring the size scale of our objects down to the really, really small regime, the nanometer size regime, a lot of these surface properties and their interaction forces become significantly enhanced, and they tend to cluster. So this is another set of particles. These are magnetic iron oxide crystals that have developed while at Johns Hopkins. We call them just the JHU particles because I'm not creative enough to spend time to think about a clever marketing name. So JHU nanoparticles. But here's H1N1 virus. They tend to do the same thing. They form these fractal aggregates. I wonder if much of what the H1N1 or other flu viruses can accomplish comes about because they form these clusters? It's a question. So, one aspect or one issue that one has to consider is that if we inject these nanoparticles into a person's blood, the body is going to treat this like a virus. So what does the body do? Well, we've developed innate and adaptive immune systems to do exactly this, to protect us against pathogens, protozoans, and viruses. So what happens? So the first step is opsonization. It's a process, opsonization, where blood proteins and other immunologic factors essentially bind to that particle, to that virus, to that protozoan, to create a surface that can be recognized by different parts of the immune system. So there is the opsonization to create a corona that now has these flags for various parts of your immune system. Let's say macrophages, white blood cells, other subcomponents of your immune system, to essentially take these particles or viruses out of your bloodstream, sequester them into these lysosomes, and then hit them with enzymes and acid to just destroy them. Okay? That's how your immune system, in a nutshell, works. So, should we be surprised that nanoparticles are not going to experience the same fate? I'm going to switch gears just for 1 second to show you that a lot of this stuff really isn't just cartoons and science fiction. So here is an example where, with a collaborator, Dr. Sean Leupold in urology, we took an anti-PSMA antibody, we attached it to the particle, the bioprobe, we attached it to the particle, and this is just in cell culture. This is not in an animal model. This is a human prostate cancer cell that expresses the PSMA protein. And then we just took electron micrographs to see what's happening. And so we exposed the cells to the particles with the antibody, and then we rinsed several times, and then took these samples to do electron microscopy. And what you see is exactly what the cartoon was showing, that when these particles there is an environment around here that is laden with these antigens, with these PSMA proteins, that the particles now are going to congregate and aggregate in these larger clusters. And that's what you see here. And what happens when the cell sees this, the cell is going to start to internalize these particles. And if one uses these guys as sort of a Trojan horse to deliver therapy, that's precisely what you want to have happen. So the question is, can we do this specifically for the cancer cells, or our target therapy target, and somehow avoid doing it with the immune system? So there's another aspect or another part of tumor physiology that is important, and if one looks in the nanotechnology or cancer nanotechnology field, people make a big deal out of this EPR effect, enhanced permeability and retention. And basically it means this: the vascular structure in the tumor is chaotic. Okay? Tumors are aberrantly growing tissues. They have all these growth factors, hormones, all kinds of stuff going on, and so the blood vessel supply is chaotic and very leaky. So this gives us an opportunity to deliver material specifically to the tumor and avoid too much retention in other parts of the body. Okay? So why even care about that? Well, it turns out that the size of these vessels, or the pores in these vessels, is actually somewhat fixed, or there's a range of sizes, and it turns out furthermore that that size is kind of advantageous for this nanometer 10 to 100 nanometer length scale. And here's an example, and this is something that I just pulled out. It's been published, but this is an example of a mouse being injected with a small molecule dye, and you notice, and it has tumors, but you notice that the dye goes everywhere. It's a red dye. And then the mouse was injected with a a nanoparticle, a fluorescent nanoparticle that was labeled with this dye, and you notice that there's accumulation in specific sites, and these are the sites of the tumor. So as a general concept, this is one area that a great deal of research has been focused on. And one of the people who's been doing a fair amount of research in this area is Justin Haynes, who's also part of the Cancer Center Nanotechnology Excellence at Johns Hopkins. He's been researching developing nanoparticles to deliver drug to brain tumors, essentially glioblastoma multiforme. And so if you can see, this is an image obtained from sections from a mouse brain that was injected with nanoparticles. The red here are nanoparticles that have not had an enhanced coating designed to minimize interactions with the proteins of the tissue. And the green particles, you notice they spread much better throughout the tumor tissue because these particles have been coated in a way to minimize this interaction with the blood proteins or with the biological system. In other words, he's trying to make the particles have a little bit more of a stealth character and to be able to slip through or move around undetected. And so when they injected these particles into mice that were bearing human brain tumor xenografts, so they actually implanted human brain tumors into the brains of mice. What we look at here is a measure of the tumor size or tumor growth. And so with no treatment, you can see that the tumors essentially grow unchecked. When the tumors were injected, or the mice were injected with paclitaxel, which paclitaxel is an anti-cancer drug, then there was some effect on the tumor growth. And when the mice were injected with a particle containing the paclitaxel that didn't have the specialized coating, well, you can see that some of the drug is being delivered. But when they added this special coating, the paclitaxel delivery to the tumor was much more efficient. It was spread out through the tumor much better, and so more of the cancer cells are killed, thereby affecting more of the tumor growth. So that's a nice application of nanotechnology, which is drug delivery. Now I'm going to move on to the next part, which is heat. Why would we even consider heat? So coming back to the theme, heat as a therapeutic agent for cancer has been known for over 2,000 years. It's not new. The trouble is applying heat specifically to cancer is really challenging because heat doesn't care if it's bone tissue or liver or cancer. So, does it work? And to just convince you that heat therapy does actually work very nicely, it tends not to work so well when it's used by itself, but when it's combined with radiation or chemotherapy, what it does is it enhances the effectiveness of existing or commonly used therapies. So here's an example. These are clinical trial data in human patients with cervical cancer. This is actually becoming standard of care in Europe. Notice, and this is a survival curve, so we're looking here years after treatment, so this is survival progression, and what fraction of the initial population survives. So we start with 100% or 1, which is all of the people who are treated. And you notice that the ones who only received radiation therapy, let's see if I can see this, about 12 years out, maybe about 20% of them are still alive. But when they combined heat with radiation, they doubled that survival, 40%. So it's a step in the right direction. We haven't cured cancer, but it is a step in the right direction. So the concept that I've been working on for over 10 years now is this concept of thermally enhanced therapy for metastatic disease. And it basically goes like this in this cartoon. Develop a nanoparticle that has this magnetic core that can generate heat when it's exposed to an alternating magnetic field, has an antibody or some other cancer-specific ligand. It gets injected, evades a lot of the immune processes immune surveillance in the blood and is able to be taken up and retained specifically by the tumors, and then the person goes into a device that would be very similar to an MRI machine, and now you specifically deposit heat into the cancer tumors for or in the context of chemotherapy or radiation to enhance control of metastatic disease. And remember, metastatic disease is the most lethal part for many of these cancers, not all. So just a little bit about what I'm talking about when I'm talking about static or alternating magnetic fields. Static magnetic fields are time invariant. In other words, the magnetic poles don't change with time. Time varying or alternating magnetic fields, the poles do change with time in a periodic fashion. These static magnetic fields are very useful for many medical applications, and one of them is magnetic resonance imaging, MRI. Alternating magnetic fields, on the other hand, are useful for therapeutic applications that might involve heat or actually being able to use them to activate some nano machine, because you can actually send signals using these alternating magnetic fields. And to just give you a little bit more of a flavor in this, the property of magnets that we look at is a property called hysteresis, and many of you might know this experiment from when you were kids. I know I loved this experiment. If you go to bed at night and you take a nail that is essentially just not magnetic, put it on a magnet. In the morning when you wake up, you take that nail off, you can pick up other nails with it. That property is ferromagnetism, and that's the property that when you take initially a magnetic substance that has zero magnetization, put it in the presence of a magnetic field, and then you take that field away, there's memory, remnants. That's the same property that if I put that material into an oscillating magnetic field, causes it to release or lose power in the form of heat, and I can generate intense heat from magnetic materials. Very often when people come into my lab, I'll take a screwdriver, put it in the magnetic field coil, and it goes from room temperature to about 3,000 degrees Celsius in 1 second. It's red hot. So that's a very effective, very efficient way of depositing energy. There is another mechanism, it's induction heating. Any electrically conducting material will generate some heat or through induced eddy currents. And so we have to be careful on the patient safety side. We have to be careful about this because tissues will heat nonspecifically in the presence of an alternating magnetic field. So if it was as easy as just sticking a bunch of magnets into a person, putting that person into a magnetic field coil, we'd all go home, we'd be done. But it's not quite so simple. And just to give you an idea, one of the things that we do in my lab is we do work very hard to build these magnetic field coils, magnetic field devices that give us very homogeneous fields in the area that we want, because the nanoparticles are going to heat based on the power of the magnetic field. And I'll show you some temperatures in mouse tumors that we've generated by controlling the heat. Therapy is going to be dependent on how well you can control the heat. So we need to have very good control over those magnetic fields. And then to just show you some examples, one example, these are the JHU particles, and then here are some examples of particles that are put into magnetic field. And the change in temperature can be very rapid. This particle here heats very well. Within about 5-10 seconds, we've increased the temperature in the sample by 20 degrees C. So you can literally ablate regions of a tumor or kill cancer cells very nicely if one can do that very well. So I had to put a little bit here from NIST. One of the things that I do is really work with people, with scientists at NIST, to study the magnetic properties of the nanostructured materials. And for this, I use the NIST Center for Neutron Research, among other things. It's a great facility. We are able to use the neutrons to study the magnetic properties and the magnetic structure of these nanoparticles, and I use that information to tune the chemistry of the magnetic nanoparticles to get exactly the kind of heating properties that I want for therapeutic applications. And this is just a slide to show you some example of the type of data one gets, and if one does the really hard work to figure out what it all means, one can actually look to see what the particles really look like and understand why they generate the heat that they do, whereas other particles might not be as effective. So using that information, here's a type of particle that you can buy commercially. It's commercially available. It doesn't heat very well. Here is a particle that I developed a few years ago. These heat very nicely, but you notice that I need to put more power on these guys, and so I run the risk of actually overheating tissue. These are now commercially available and are in clinical trial at Dartmouth. And these are the particles that have developed while at Johns Hopkins to essentially dial back the magnetic properties so that I get heating. It's not necessarily as intense, but I can get more heating at low power. And so what does this all mean when we start to actually inject these into models of cancer? So here's my bioprobe again. My magnetic nanoparticles, this is the part that actually generates the heat. This is the business end. The rest of it is really just to avoid detection by the immune system and also achieve preferential retention in the cancer tumor. So I do a lot of this engineering and chemistry to just get the particles there. So mice bearing human breast tumors were injected with these particles. So the antibodies is just a chimeric L6 antibody, CHL6 antibody that is specific to a protein that is produced by these tumors. So the purple or the blue bars are, and these are the tumors. So what we did was we injected this material, and 3 days later we harvested the tumors and other organs, and we looked to see how much of the material was in those tissues. And if we look at just the antibody, we get about 18% of the injected dose by mass is in the tumor. When we look at our functional antibody labeled nanoparticle, we actually didn't do too badly. We have a fair amount of the material in the tumor. And then as a test or a control, we inactivated the antibody in other samples and we injected those, and look what happens. When the antibody isn't working very well, then the particles don't stay in the tumor, and they end up liver and spleen mostly. Liver and the spleen are these organs that function as part of the reticuloendothelial system, part of the innate immune system, where a lot of this material that macrophages that are constantly surveilling will gobble up and deposit. So these materials, many of these nanotechnology products, if one isn't very careful, one actually ends up having, as soon as they're injected, they end up in the liver and the spleen. They don't have a chance to get to the target. So one of the things that we have to work very hard to do is to actually achieve a long enough circulation time in the blood so that these guys have a chance to get to the tumor through the enhanced permeability effect, and then by using that antibody or that other molecule that specifically binds to a marker on the cancer cell, keeps it there. So when we do all of that and we apply our heat, what happens? So these are tumor growth data, and these are tumors that where the mice only had the bioprobes injected. These were mice that were exposed only to the magnetic field, and then these were mice that only had that had no treatment at all. And so you see that these are controls and nothing happens. When we expose the mice after injecting the nanoparticles, 2 days later we put them into the magnetic field and we initiate the therapy, we generate heat inside the tumor and we kill tumor cells. What's interesting about this is that we can dial in how much therapy we want. So here was at one power setting and here was at another power setting. So we actually inflicted enough damage to these tumors to delay their growth significantly. And then we took electron micrographs and we actually see that mice whose tumors were exposed to the alternating magnetic field actually had destruction in the tumor. Another example of this similar thing, I'm sorry, I don't know which button I pushed, but clearly. So very quickly, this is coming back to the PSMA antibody. So here's an interesting model. We grow two tumors on the mouse. One tumor is PSMA negative, the other tumor is PSMA positive. That's actually kind of a cool system to use, because now if we inject our particles, if they're really working, they're going to go to one tumor and not the other. Yep, that's exactly what we saw. Antibody labeled particles, PSMA positive tumor. Here's the PSMA negative tumor. Particles without the antibody, not much difference in either tumor. And then we did some MRI contrast, so you're looking at a sagittal view of the mouse. These iron oxide nanoparticles, they're what's called a T2 contrast agent. So when you put them in an MRI, when they are present, the image gets darker. So here's a tumor without the particles, and it's brighter than the one that has the particles. So, pancreas cancer, lethal disease. Diagnosis is usually, the prognosis is usually pretty much a death sentence. 5% chance of survival. One of the problems is that it's asymptomatic until time of diagnosis. And time of diagnosis, there's usually some pain or something. And when it is diagnosed, it's locally advanced. There's a very large tumor that is often inoperable. And the interesting thing is it's kind of resistant to radiation therapy. And in fact, the radiation oncologist cannot give it a high enough dose without actually causing excessive damage to the sensitive tissues nearby. So we decided to test our approach in a mouse model of pancreas cancer, where we actually have large and small tumors. And the sizes of these tumors are controlled. And of course, this is a mouse model, so everything is much smaller. But we noticed that with radiation, this is a 5-grade dose, a particular dose of radiation, indeed, the larger tumor is more resistant than the smaller tumor. Just to give you an example of how well we can control the heat, we can control the heat to a prescribed thermal dose. We injected the nanoparticles. In this case, we injected them directly into the tumor. And by modulating the power or so, we can control the tumor temperature to a very specific value. Doing that, we find that, okay, yeah, we actually do better with the larger tumors. So compared to radiation alone, it's an interesting effect. Where radiation fails, we actually succeed. So larger tumors are actually better for us. So this is an ongoing study. And I'll just show you the last little bit here from this study, where we combine the radiation with the nanoparticle hyperthermia. These are just the small tumors. But notice that even for the small tumor, when we combine radiation with heat, we get a very significant delay in the tumor growth. So we really do cause an effect. So with all of this seeming so promising, and I'm just going to wind down with this, with all of this seeming so promising, what do we need to do to translate more of this into the clinic? So the benefits, I think, from the science are really quite clear if we can engineer the particles well. We can potentially address metastatic cancer. So what's the challenge? The challenge is this. It's a regulatory risk. It's a new technology. It's undefined. There's no really good experience with how to actually put this through the system. So there are chemical manufacturing and controls that need to be addressed. There's toxicity assessment, and then there's also the question of how is this going to actually go through the regulatory process? Because what I've showed you, particularly these antibody or these other molecule conjugated nanoparticles, you have a biologic, you have an injectable drug, the nanoparticle, and then you have a device. So it's very complicated. It's a great technology, it's a great idea, but it's extremely complicated. What does that mean? Well, it means it's really going to take a lot of work, a lot of money, and a lot of time to get it into the clinic. And just as a reference, for small molecule drugs, for which there is a well-defined path, it takes, just to get to the first clinical trial, it takes about $20 million in 5 to 10 years. and most of them fail. So that's just to give you an idea, and this is why there needs to be a sustained commitment to address such big problems. So one of the strategies that I think could potentially work is we want to develop a realistic path to the clinic. So we want to address some clinical unmet need by a simplified version of this. So that simplifies our chemistry, that simplifies our toxicity and all of our regulatory concerns. Mode of administration should be local. What diseases, what cancer indications can be benefited by a local mode of administration? And for those, I would argue liver, pancreas, and brain. And I didn't highlight it then, but if one looks at the cancer death rate, pancreas, flat, liver, actually starting to go up. So it takes a fair amount, actually a lot of work. Cancer is a very complex set of diseases that involves the immune dysfunction, immune dysregulation. It involves genetic instability. It involves epigenetic instabilities. I think nanotechnology, because it is actually in the size range of something that we have been naturally selected to deal with, that offers us an opportunity to, with the right control, to be able to take advantage of tools that we develop, of what we learn, to really specifically home in on certain diseases, and even to modulate or reverse certain diseases, other diseases. So the potential exists. The potential also exists to enhance current or existing therapy. And at least in the case of magnetic nanoparticle hyperthermia, with the right engineering, with the right tools, the right collaborations with scientists at federal research institutions, we are able to develop particles that produce very specific heat doses to be able to cause the damage that we need. And with that, I will end, and I'll leave the slide of acknowledgments, because a lot of this work over the years has taken a great deal of effort, many students, many very fine collaborators at Johns Hopkins, at NIST, and other institutions. And with that, I'd like to thank you for your attention.
Do you have any questions?
You've been working on this for 10 years.
Yeah, over 10 years.
Over 10 years. And you said about the challenges in regards to the timeline and the money associated. Where do you think this is at from where you are now in the timeline? Are we looking at 5 to 10 years out from the path that you're on?
So the current path that I'm on developing the strategy that I laid out was, let's say, the untargeted version where we locally administer the particles. I would argue that we've developed the particles. So before I answer, let me just give you sort of the background or the rationale, thinking like a typical physical chemist. We have a significant amount of data in mice, rats, and even rabbit models of liver cancer, pancreas cancer, breast cancer, prostate cancer. So we're fairly confident that there is good therapeutic potential to move this into the clinic. Our manufacturing is reproducible. In fact, these particles were developed not specifically in my laboratory, but in collaboration with a company. Again, because I anticipate, just from really developing this from the ground up with scalability, manufacturing controls, and all of that built in. So I would feel very confident saying with the right money, that version for, say, pancreas cancer could be in a clinical trial in 2 to 3 years. Yes?
I'm curious about the fate of the particles after you heat them in a model animal body. Are they destroyed? Do they migrate to other cells? Are the ligands vulnerable to thermal degradation?
That's a very excellent question, actually. So what happens during the heating process? This is an area of research. One of the people on here, my current postdoc, Anil Adaluri, he's a mechanical engineer, and this is one area of interest for him, is modeling what actually happens during and immediately post-heating. So what there's a complex series of physiological and mechanical changes that occur in the tumor during heating. Tissue expands, it becomes much more pliable, increased blood flow comes in, and so and also there is concomitantly tissue destruction. So the particle distribution inside the tumor will become modified. Okay, so now depending on the type of damage and the extent of damage, the process of, quote, healing, resolution of the damage, has a further impact on what happens to the particles, because now you have various components of the immune system, macrophages and so on, coming in to clean up the debris and the mess. They may take up the particles. And so sometimes what one finds is that the particles just stay where they are if you've destroyed enough tissue that nothing really gets in there. Or they may actually migrate, the particles get moved out to some other periphery or some other zone nearby, or get transported to the draining lymph nodes, and then eventually end up in the liver. So my guess would be that, because I've never actually done this experiment, but my guess would be that an extremely successful therapy that eradicates the tumor would probably result in the particles ending up in the liver and the spleen, because that's their ultimate fate anyway. Yes?
In your studies with the now, since it hasn't been doing clinical trials with patients, have you compared the impact of radiation and chemotherapy in the rats in comparison to what you're doing with the neo material?
So let me ask if I ask you the question, or repeat the question just to make sure that I understand it. Have I compared the effects of radiation plus chemotherapy in an animal model with the nanoparticle heating? Is that correct?
Yes, that's correct.
From which perspective? Toxicity or
The effectiveness of it and
the-
the toxicity
Okay.
also.
So the answer is yes, but not completely all the way there yet. So in much of the work that we've been doing, one of the things that we do for the effectiveness is we do look to compare between the nanoparticle hyperthermia, radiation. I have not done chemo. I haven't done as much. Actually, I have done no chemo, or models with chemotherapeutic agents. But radiation compared with the nanoparticle hyperthermia, and then in combination. And typically what we see, the nanoparticle hyperthermia is usually not as effective as the radiation, or it's comparable to effect of radiation. But when it's combined, there seems to be an enhanced effectiveness. And one of the other interesting things that we see is that because of that, we can actually potentially use a lower dose of radiation to minimize the toxicity from those therapies. And what we also see is that we don't have overlapping toxicities. Now, we haven't pushed the limits, at least on the nanoparticles, to see where the toxicities lie, but at least as far as the heating, as long as we're controlling the heat dose, we don't have toxicities that overlap. In other words, we're not making the problem worse. What we do see instead is that radiation has specific toxicities when we hit a high enough dose. The heat therapy also has specific toxicities when we hit a high enough dose, but they're not the same. And because we can combine them and use a lower dose to be more effective, we actually don't see the same type of toxicity and toxic effect. And that's really the significant benefit and the significant hope. Radiation oncologist, friend of mine and collaborator who deals with pancreas cancer, he looked at our data recently because his postdoc just recently presented this at a weekly meeting in the department. He said, this is the most exciting thing I've ever seen, because his big challenge is that he, as a radiation oncologist, cannot deliver a high enough dose to the pancreas tumor without causing damage to the duodenum and other very sensitive structures that are right nearby. So yes, that's a very good question, and that's exactly where we take our research, is to really look to see how to effectively combine these two to get the same or better effects, but with a much lower dose.
Well, I think that you should add comparing that to chemotherapy I'm a consumer advocate for CARA, and I sit and listen to a lot of RFPs for the National Cancer Institute as an advocate. And some of the clinical trial questions, because I'm coming from the patient standpoint, some of the clinical trials has proven in many areas that chemotherapy long-term, and the reason why I can say that is because I'm a 4-time cancer survivor of now 38 years, and I went through the 70s and 80s with chemotherapy and radiation, and I've had long-term effects that have affected me. And I think that if you start looking at your research going in the direction of comparing the toxicity in the long terms of chemotherapy as that part, and then your nanoparticles as another part, in doing that comparison study, I think that may be more of a bid to get something for RFP and get that funding.
Would you like to co-write my next proposal? I completely agree with you. And absolutely, this is a discussion that we always have internally in my research group. The fact is that for every added therapeutic modality, one has to include not just an additional cohort of animals, but it actually takes 3 or 4 more because you need all of the controls. So absolutely agree. But a trimodal therapeutic study would require a really sizable study population of many different cohorts, and that's where I actually run into the challenge. It takes more resources to do that. And so if you want to join me in writing a grant proposal, I'm all for it.
There was a study I was put in many years ago, back in 1977. And I think that if you came back and looked at survivors, if you actually plugged in the survivor community and see the long effects of that, then that may be something, that may be a bidding piece for you, because the fact that a lot of survivors who were and then had who are actually still living, one of the few around. But the point being is that in that case, you would see chemotherapy is much better now, of course, but the fact that the long-term effects sometimes, if you do manage to be a survivor, there are a lot of things far out that affect you.
Completely agree. In fact, and I'll just add to that, I didn't highlight it, but I don't know if any of you have noticed the leukemia rate is going up. That's one of the effects of chemotherapies. It's absolutely 100% correct. I would love to do that. Yes. Okay.
I have 2 questions for you. One, you mentioned something about Dartmouth.
Yes.
What is the name of that study, or how do I find out?
That's actually, so the PI on that is Professor Jack Hoops. He has been doing it's a canine clinical trial for oral sarcoma.
Okay.
I'm not sure how much of that, I'm pretty certain he hasn't published anything yet.
Okay.
So it is a legitimate clinical trial, only the patients are not humans, they're actually dogs. So spontaneous tumors and so on. I'd be happy to put you in touch, and if you're really interested, to follow that up.
And how do I find out more information about what you're doing? I mean, I saw that a couple of things were unpublished, and so...
Sure. I can give you my card.
Okay.
Very simple. Happy to talk.
A very quick question. First, thank you for making complex things as simple as possible. A layman's question to follow up on other gentlemen's. This sounds so intriguing. At the same time, I wonder, the animal experiments that you do they live long enough, for example, for you to get an idea of the rate of clearance of these nanoparticles through the liver and the spleen and out of the system? Do you have an idea how long they remain? And do you conceptually see any potential problems that you mentioned? Some of them tend to stay in situ if they effectively destroy a tumor. Jumping ahead, so this is obviously, I'm asking you to think possibilities.
Yep.
Do you think there would ever potentially be a problem with, given the heavy rate of MRI usage, of someone who had a tumor clear, going through this kind of equipment and having these particles reheat in a way that's damaging the tissue in the future?
I think there are two questions there. So to answer the second question, let's go to that second question. I'm not sure, but I can guess that it's probably not going to be a significant issue because eventually these particles are degraded so that the magnetic properties are decomposed. The iron retention in humans is actually fairly long-lived, but the particles depend very much on this very specific magnetic anisotropy energy, which depends on the structure and so on. So macrophages are just going to pound away on them. So long-term, I wouldn't expect there to be a problem, number one. Now, to your first question, I smile because, first of all, to answer it, the answer is no, we don't go long enough, but here's what I think we haven't really clued in on. I wonder if the animal models we're using are actually even appropriate. Because what I showed you were data from mouse or human tumor xenografts in mice models. Okay, so what that means is we implanted human cancer cells to grow human tumors in mice. The only way you can do that is if you use an immune-compromised strain of mouse. Yeah. If the nanoparticles are like a virus, then its interaction with that immune system has absolutely no bearing on what you would expect to see in a human. So that's one of the areas that I'm really thinking, and I've been writing proposals on this, and they don't get funded because people don't think it's important, I guess, I don't know. But I think it's actually important that we need to take a re-examination of the nanotechnology, the models we're using, particularly for cancer, and bring some parity for how we align or what kinds of models we use for which studies. It's a very good question. Probably didn't expect that long of an answer. Yes.
You reference 300 different types of cancers, most of whose etiologies we don't even know or understand, most of whose histologies we can't even differentiate. Yeah. And consequently, when you talk about metastatic cancer, you haven't really talked about when it has moved from the prostate, say, to the lymph node. And I have small cell right now, and it's moved to the lymph nodes, and it's essentially we're going to be playing whack-a-mole on it, and I don't see how the ferrous oxide particles are going to be trained to go to the lymph nodes after they're in the prostate.
So there are, and I'm very sorry to hear about that, but. So there are two different strategies or two different approaches that I admittedly kind of mixed up. And so one is to address disseminated disease, and the other is locally advanced disease. Locally advanced disease involves image-guided, if you will, but image-guided interventional therapy where the nanoparticles could be directly injected into the tumor, and then we heat it. Okay. I didn't focus on this because that would be a whole different talk. But I believe, and there are significant amounts of data coming out now in the past 2 years showing that heating of tumors has a profound effect on the immune system to modulate the immune system to re-engage it for cancer therapy. And that's, I think, an interesting and an exciting proposal, but that would require that the heat therapy and also radiation would have to be done in the context of vaccination, cancer vaccination. People are doing exactly those kinds of clinical trials right now. So to answer that question specifically, that would be the way that I would approach addressing disseminated disease, probably in the best possible way. Hit the main tumor or hit one of the tumors and re-engage the immune system, reverse the energy of the CD8 positive T cells, if you will, to now then home in on and start hunting down the other tumors. On the other hand, I also showed some work that I've been doing with molecularly labeled, ligand-labeled nanoparticles that are specific to particular markers, antigens, or other proteins on a cancer cell surface. It turns out that in many cases, the primary tumor, when metastasis or dissemination occurs, it's a particular subclone of the original tumor. So it tends to be that the metastatic sites are less heterogeneous than is the original tumor. So it turns out if you find that correct marker, I think, I don't know, find that correct marker, label the particles with that correct marker, systemically deliver, intravenous delivery, and again, with all of the other caveats having been discussed, hopefully enough, long enough circulation time and a good specific binding to those cells. So, two different strategies.
Thank you.
You're welcome.
Maybe you can talk to him after this, but please join me thanking Professor Ivkov.
Thank you for your attention.
This has been a presentation of the Library of Congress. Visit us at loc.gov.